Welcome back to lesson 3 in Beyond Behavior. We're talking about a trauma-informed approach to ABA practice. In lesson 1 and 2, we talked about research. We talked about starting to assess for trauma in our initial meetings and talked a little bit about screening. In this section, we're going to talk about trauma-informed care in practice. So my hope for you from this section is that you leave this training with some concrete things that you can start to do in your own practice to help move towards more trauma-informed care. I always tell people that if this is a big change for how you practice, we're really looking at really small steps that we can take until we get momentum going to integrate more informed trauma care. So we are going to talk a little bit about how we talk about trauma. We're going to talk about how we integrate some specific things into our sessions. What I'm going to ask for you to do is while we're going through this lesson is to really think about any of the skills or any of the things that we talk about that really kind of resonate with you or feel like they are a good place to start, because I'm going to give you some tasks at the end to really think about what our next steps might be. So the first place to live in is talking about trauma. And I know we talked a little bit about this in lesson 2, but I wanted to spend a little time, kind of diving into it a little bit deeper. If I could pick one kind of overarching frame about talking about trauma, I can't, so I'm going to give you 2. The first is that when we talk about trauma, we are working to educate our clients, families, stakeholders that we're working with. And the second one is to gather information, just enough information that helps inform how I'm going to design behavior interventions, behavior plans, what language I'm going to use moving forward. So we're really looking to educate others and inform practice. Those are the 2 kind of primary things we're doing when we're starting to talk about and assess trauma. One place to start is to really educate clients, collaterals, whomever it is that you're working with about trauma from a behavior analytic perspective and how it impacts behavior and functioning. So I would not recommend going to a large meeting and starting to talk about motivating operations and coming into contact with stimuli, right? Because we want to make sure that we're not using a lot of jargon. We want people to really be on board with the approach that we're taking to treatment. So we might talk about when people experience traumatic events, if there are things that are in the environment that later in life, those similar things might contribute to behavior, right? We're really looking at when somebody was young and experienced a traumatic event, their access to reinforcement looked like this. And we can see how that's impacting behavior today in this way. So we're really starting to think about the fact that trauma or a trauma event happened is one thing, but we're really looking at starting to connect that into behavior and environment today. We want to talk about the possibility that if somebody is experiencing sleep disturbances, if they're having physical symptoms, if they are, more reactive in certain situations, that we're really looking at this through the lens of reinforcement and how stimuli are paired in the environment during the time of the trauma event and how we might be seeing that as a trigger in the environment now. Hopefully that kind of really wraps up the motivating operations. I was joking with Amy that, and I think I said it before, I just really have a hard time sometimes talking out loud about motivating operations, but I know what they are. And part of our job as behavior analysts is to be able to explain it to other people. So I am always learning. And I'm always interested if somebody has really good explanations about it. You should have an option to be able to put questions and, thoughts in the forum below, and we will read all of your answers. So I'm hoping I can learn from you a little bit as well. We want to communicate that treatment is important in learning functionally appropriate replacement behaviors, right? So we're talking about that anyway. That learning functionally appropriate replacement behaviors really can help with client outcomes, positive outcomes, and that when we have information about trauma events, it can help us start to formulate what functionally appropriate behaviors are appropriate in certain environments. So we never want to teach blanket skills. I mean, some of them are important, but if I encounter a specific trigger that's tied to a trauma event, my replacement behavior might look a little bit different than a similar like escape contingency, right? Because I'm not only responding to the behavior, I'm also having knowledge of the fact that there may be something that's contributing to that behavior from a trauma perspective. We will try to educate the links between trauma and the impact that it has on private events as well as public events. And I don't know, this might be me going off script as a behavior analyst, but the cognitive behavior triangle, where we look at thoughts, feelings, and behaviors and how they're connected, sometimes is a really nice visual to use with people to talk about like our private events, right? Our thoughts and our feelings can influence our public events or our behaviors. And when we teach functionally appropriate replacement skills for behaviors, it can have an impact on the private events that we have a hard time measuring. And it allows us to talk about those possible reinforcement systems from a perspective of the whole person, not just the person's behavior, which I think can be really important. We, again, are going to try and normalize trauma responses. So I will often use words like, it is very common when people experience a traumatic event that we can see impacts on behavior in this way. It is normal, or I like the word common. I try to avoid the word normal because like, what does normal mean? But right. Many people will show these behaviors or will engage in these reinforcement like systems when they have a traumatic event because, and I will try and normalize it that way. We want to be clear in our communication. So if you made it this far in the training, you can tell that I am a talker, and I use lots of words. When I talk about trauma, when I explain interventions, I really try and keep it as simple as I can. I try to avoid all of my filler words that I use, and I try to be very aware of how I'm communicating the information that I'm communicating. I don't know if you can see my little face screen, but you probably have seen my hands pop up a lot. I'm still working on it. I'm a hand talker. If I'm doing this when I'm talking about, trauma, it's probably not the most helpful. So being aware of my own responses and my own presentation in those meetings can be very important. We want to try and integrate trauma assessment or screenings or even just questions about trauma history. So I will often start with, I would like to talk to you about any possible traumatic events that may have occurred in your life, right? Or in your child's life. And that is a very broad conversation. You can share whatever you would like. I'm going to ask you questions that if you don't want to answer, you don't have to. And the reason I'm asking is because, and then I'll give information about why I'm asking. That does a few things. Again, it allows for choice in conversation, which sets the tone for how you provide services moving forward. It also lets them know that you are not unaware that trauma has an impact and you are not uncomfortable with trauma. If people feel like you're uncomfortable, they will not tell you about their trauma history. And the third part is it allows for you to offer messages of hope, which I know is such a unmeasurable word, but really kind of saying having this information really helps us figure out the most appropriate interventions to use for you or your child or whomever, we're talking about, and will help things feel better or will help behaviors improve more efficiently and effectively, right? So even that language is like, hey, things can get better, right? That's what we're aiming for. And then just make sure that you're talking about it in regards to the interventions, the functionally appropriate behaviors that you're looking to see, and how you're going to integrate your own like kind of practice into those sessions. Language is really important when we're talking about trauma-informed care. And I always love this this reframe. So I use this all the time. So because I'm human and I feel frustrated with others sometimes. So I want you to imagine that you are with a coworker and you are working on something and there's something that they're engaging in, some behavior or language that you find really frustrating. Or if that's a hard one, think about a group project that you worked on where one of your group members was not contributing in a way that you felt would be helpful. And we start to feel frustrated. And our first kind of jump is to, oh my gosh, what is wrong with this person? This isn't hard. We have our rubric right here. I don't know why they're not doing the things that they need to do. And just imagine if in that same situation, everything's set up the same. Group project, they're not engaging in the things they need to. I'm starting to feel frustrated. And instead of saying, what is wrong with this person? I said, I wonder what is happening for this person right now that's making this difficult. I wonder how this person is doing, right? I wonder if there's something that is impacting this person that's making it hard for them to do parts of the group project. And really kind of start to think about just that shift in language. One comes from a place of compassion and understanding. You can still be frustrated. The other one comes from a place of blame and kind of, assumption that somebody is like purposefully not doing something. And when we can shift how we start to talk about environmental impact, I'm not saying trauma even, just like things that are going on, and we start to think about things from a trauma-informed lens, it allows for us to be more compassionate in regard to people's responses. So when I'm working with a family and they are not engaging in services, or I've met with a parent multiple times to do parent coaching or parent education, and we're talking about these things that I know would be really helpful in home, and the parents are not following through. And I'm like, why is this parent not doing what I'm talking to them about? Imagine how different that would be if I met with a parent and I said, I'm wondering what is happening that's making it hard for you to engage in the things we've been talking about. I'm wondering if there's something that's going on in life for you. Is there something about the information I'm delivering that is not helpful, that is making it hard for you to implement this at home? And really start to think about how we are continuing to build relationships and rapport. How much more open might a family be or a client be if we approached with, I wonder what's happening that's making this hard, versus you're not doing something. What is wrong with you? So I really encourage, and honestly, even if this is the one thing that you do from this training and you can find some ways to start to integrate and catch yourself and ask that question, I know from experience, I don't have any data, but I've supervised many people. It allows for us to really meet clients and caregivers and stakeholders where they're at versus assuming poor intent on their part to engage in services. So when we, and what happened to you allows for strengths-based and problem solving, right? What is wrong with you really kind of shuts the door. And so we're really looking at how we're using language to connect with other people. We want to use strengths-based language versus deficit-based language, which I know can be hard. So when you're filling out things for insurance companies, we don't want to be like, yay, Nikki met 80% of her goals. Can I still have, the hours I need for the week or for the month? Because it's hard to get time. So the medical field and insurance company looks at what's not going well. I encourage you to really think about where we're building strengths and resources and skills, and use language that allows for us to move in that direction, even if there are parts of our professional life where we might have to live in a more deficit-based or what people aren't doing yet. Thinking about how we teach skills and using the least intrusive interventions is something that goes along with the current kind of recommendations in ABA. Really thinking about trauma-informed approach can also enhance our practice by really looking at how we're providing less intrusive interventions. And we'll talk a little bit about restraint and seclusion. We're going to talk a little bit about in a few minutes. But, be aware, again, I said this earlier, that some words and intent based on language doesn't translate if English is not the first language of the person that you're working with. And so again, if you can get an interpreter to help with services, I really do recommend looking at that. When we are supporting our clients, many of our clients come in with complex needs. So they may have medical, mental health, communication needs. And it's really important to consider how we are integrating with those other service providers. So my primary experience has been working with individuals 0 to 25. And when I specifically work with individuals under the age of 18, they often have multiple people that are involved. So I have a client right now who is involved with OT, PT, speech. They have a prescriber. They go to school. They have an outside provider to work on other kind of functional skills. They have me, and I know they have other people, but that's 7 providers that I just listed. And so when we start to think about how many systems our clients are involved with, it's helpful to start to think about how we approach treatment from an interdisciplinary approach, which is all disciplines working together, versus a multidisciplinary approach, which is where all of the services kind of work independently of each other. When we work from an interdisciplinary approach, there are a ton of benefits. We can work on joint goal development, even if the services and the interventions look different based on the discipline. We're all working towards a common goal. It helps for more effective evaluation of progress. It allows for problem solving. It can improve client outcomes, right? So if my team is working together, it helps with outcomes because we are all communicating about information that we might need to benefit how we're providing intervention and managing sessions. Now, reminder, most of the time we do need releases of information. So sometimes we may not always be able to work in collaboration with others, but I do encourage in the, kind of assessment for services and the importance of collaboration of educating families and clients on why it might be beneficial for us to be able to communicate with other service providers. It allows for us to address multiple presenting needs simultaneously and comprehensively. So really thinking about if somebody is experiencing, specific behavioral challenges, and I'm the only person who has information, and I can't talk to anybody else, but I also know that there are communication challenges, there might be mental health challenges. Without being able to communicate about that, it really does make it difficult to see significantly improved client outcomes. One other thing that it really does is it can create feelings of efficacy within team members. So if as a provider, I'm able to collaborate with others and we problem solve and we work as a team and we get feedback and it informs my intervention and I see my client making bigger gains because of that, I feel more successful at my job, right? I feel more successful as a provider, and that can impact how I move forward in relationships. It can impact my satisfaction at my job. It can have an impact on compassion fatigue. So really thinking about collaboration, primarily benefiting the client and their caregivers, but also having kind of outside benefits in regard to working with others and our own efficacy in our jobs. And if you're interested in reading more on that, Broadhead article, I think I put in the references from 2015, noted that behavior analyst engagement in collaboration can also aid in the dissemination of applied behavior analysis practices. And it really allows for us to represent ABA and the field of ABA in a positive light when we can work with other members of other disciplines. All right. So just something to think about when we're talking about collaboration. Oftentimes, depending on where you work, collaboration is very important. That should be no matter where you work. But sometimes insurance companies won't pay for coordination of care activities, even when they're required. So I'm always interested to hear what other people might have for problem solving around this. So again, feel free to drop that in the forum below if you have any thoughts. But really starting to think about how we can integrate collaboration in a time effective way if we aren't getting reimbursed for it. I live in this place of I understand reimbursement is important, and how do I look at what is really impacting client outcomes? And if collaboration with other places or other disciplines is something that's important, how do I start to build that into my practice a little bit differently? In addition, something else to think about is that our ethics code really talks about benefiting others, which is one of the principles of our practice. And it states, effectively and respectfully collaborating with others in the best interest of those with whom they work, and always placing client interest first. So we find ourselves in this really weird spot where we know that collaboration is important. Ethically, our ethics code for BCBAs states that we should be collaborating with others respectfully in the best interest of our clients. But then sometimes we hit a barrier where, we feel it's important, but we're not getting reimbursed from an insurance perspective for the time that we're spending in collaboration. And I don't have a solution. And I've always found that one of the hardest things of practice is where ethics, agency, practice, insurance reimbursement, and the law, when any one of those don't align, it creates a lot of challenge with how to move forward in the services that we're providing. I encourage you, if you are experiencing this, it's something important to talk about with your supervisor. I do have to say that I was lucky in the last agency I worked at that we did get paid for case management-y type services. We could get paid even for some collateral meetings, but that is not true for every state or every insurance payer. So really looking at how we start to move forward in the field of behavior analytics to provide the best quality care that we can for the people that we're working with, and making sure that we are continuing to refer back to our ethics code and refer to our practice policies to make sure that we are always acting in our client's best interest. Something that we've talked about a lot, I hope it has stuck out to you in this training, is really looking at a safe environment. If you are interested in reading peer-reviewed journal article, the Rajaram article from 2022, again, it's in the references, was a really good article about trauma-informed practice. And he talked a lot about how we start to operationally define some of these trauma terms, right? So what does it mean to have a safe environment, right? How do we define that? How do we start to integrate that into behavior analytic practice? So he noted that defining a safe environment might actually be one of the more straightforward terms to define. And he identified safety, suggests that one is free of impending harm while behaving in a context with minimal aversive stimulation, as indicated by no or minimal engagement in avoidance or escape of that context. So really looking at how we start to operationally define some of these more vague terms so that we can integrate it more effectively into behavior analytics. The trauma-informed care principle of a safe environment really encompasses more than just being safe from attack or abuse. And this is where things get a little tricky because it talks more about a feeling of being at ease or comfortable in an environment. And how do we start to measure that as behavior analysts? So really starting to think about how our environment can create opportunities to access learning more effectively. And are we adapting the environment to meet the needs of the individual? Now, this might be easy in the context of if I'm one-to-one, but say I work in a classroom, or I am in a situation where I'm in a clinic where there's multiple clients in one space. Again, this is where it's helpful to live in a trauma assumed perspective where I'm going to create an environment that promotes independence for everybody. Am I able to minimize any possible sensory triggers am I teaching the clients to cope with triggering stimuli, or, find functionally appropriate ways to remove themselves from those triggering stimuli? So I will share a personal kind of story for this, but I remember a time in my life when I was seeking out medical care and I needed to see a specialist. So my primary care office is quite lovely. It is very soft lighting. They have like sensory safe spaces, which I've never accessed, but for people who need, a little bit quieter, they have like a separate waiting room you can go into that is much more dim. There's like a sensory swing in there, other kind of sensory stuff. The walls are this like lovely shade of blue gray, but not like the sad, depressing blue gray, like a really nice blue gray, no fluorescent lights. The front desk people like speak in very calm and, welcoming voices, which has not always been my experience in a primary care office. They have the waiting rooms are clean, it's wide open spaces, there's culturally diverse art. Like you kind of think about the most perfect safe space or safe environment for a doctor's office. Like, I wish I could share my doctor's office with all of you. I got referred to this specialist and I walked in and it felt institutional, right? Cement walls, flickering fluorescent lights, no private spaces to check in. So you were in this like huge milieu and just sharing personal information when you checked in. The waiting room was crowded and small. But the thing that stuck out to me the most is they were playing this really loud, like, music. And it was polka. And I'm not averse to any like polka kind of music, but it just seemed an interesting music choice for a doctor's office. And so I remember going in and meeting with the doctor, and I asked the doctor, I'm like, why polka? Right? Because it's just like interesting. And I asked if like his patients liked polka, and that was why he played. And his response was like just totally blew my mind. He said something to the effect that his patients only had to tolerate the music that was playing for the time of their appointment, but he had to listen to the music all day. So he just played what he wanted, and it didn't matter if other people liked it or not. So now I'm sitting in this room with this person I met for the first time, and I was like, wow, that was wow. All right. Had my doctor's appointment, never had to see him again. I was fine with that. But from a trauma-informed perspective, right now, like kind of putting it in the context, his response was not very informed about the experience that his patients were having when they walked into his clinic. And he put the needs of himself ahead of the needs potentially of his patients. Now, I'm just talking about music. Sometimes we can't manage the environment of a waiting room. It is, sometimes we get what we get. But there was choice and control that he had over the music, but his response was so interesting to me. And I really encourage you to start to think about the environments that you enter as a patient or somebody who is seeking services, like where you're the client. And are those environments safe? Do they offer ability to access the information that you needed? Now, the polka music was playing in the exam room loudly. I was able to manage that and gather the information and have a conversation. But what happens if I couldn't? How much am I accessing care if the environment that I'm in is a barrier to that? So I noticed behavioral changes in myself. I talked louder. I definitely I'm a fidgeter. So I was tearing at the paper that was on the little exam thing. I felt a little snappier. So my language was more direct with him. And those are mild behaviors that I could manage, but imagine how our clients might respond. Think of a situation where you may have had a hard time and what your behavioral changes were based on the environment. And so when we're talking about safe spaces, what is the likelihood that I would have gone back to see that provider? And what if he was the only provider I could see for the service I needed? And it might look that I am like I'm not engaging in his services, but what's happening is the rapport and trust and the environment were not set up for me to feel like I was in an environment that was conducive to my learning or to my treatment. And so we start to really think about that context. So I just give that personal example so that we can start to think about how we respond to environments that are not set up to be safe environments and how that impacts our ability to access care. And then we can start to apply it out to our clients who may have baseline kind of difficulty accessing care, and then the environment makes it even more difficult. Something to think about, and that, I have to give credit to Amy for this slide because I was writing my presentation and I sent it to her to look at, and, she sent back some really helpful comments. And one of them was, how do we help parents create a safe environment at home, especially if home is a huge stressor or a huge part of like the challenges that we're seeing. And so I thought maybe we could talk a little bit about this. And one place to kind of consider starting is how we look at using our trauma-informed assessment, not only to assess traumatic events that have occurred in our client's life, but also traumatic events in the context of services that may be occurring in the home or with the primary caregiver. So I don't know if this story will sound familiar to many of you, but we work with some clients who have some very challenging and potentially unsafe behaviors. And I've worked with many caregivers who come in and their child is physically aggressive toward their parent or caregiver. I remember having a parent come in one time and they had a black eye. And because I sometimes forget to have a filter, I was like, oh my gosh, what happened to your eye? Right? Like, it's the first thing I see. And the parent was like, oh, the client had wanted access to their iPad. The iPad battery was dead. It had to be charged, and engaged in aggression and punched the parent in the eye, resulting in a black eye. And sometimes I find myself in the context of like, oh, okay, let's talk about challenging behavior. But if we're sending parents information that their experience is not important in regards to trauma perspective, then we might see challenges with engagement. So prospectively, this parent was being abused by her child. Now, I'm not living in a place that the child was intentionally trying to harm the parent necessarily. I live in a behavior analytic perspective of like, what's contributing to the behavior? How do we kind of teach like the functionally appropriate replacement skills, look at reinforcement systems, and is that a traumatic exposure for the parent that now makes it more difficult for them to engage in the same way when their child's experiencing challenging behavior? And then I come in and I say, oh, well, let's try this differently without talking about the fact that the parent just experienced something traumatic. And so when we work with families or care providers and there's possible trauma exposure at home, it's important to assess for that, because now I'm going to start to think about trauma-informed care as part of the family system, not just my sessions with the client. And when I start to do that, we start to look at things a little bit different. So if a parent has a trauma exposure to their child who is constantly physically aggressive to them, they are going to have their own reinforcement systems, their own motivating operations, their own behaviors that are occurring that sometimes need to be managed or skills taught before they're going to engage in the interventions that we're talking about for their child. And so this is starting to look at the context of the whole family, or like when a community experiences a traumatic event, right? I think about COVID, and then we have these kids going into school with, and teachers are managing behaviors, but those teachers may have had traumatic events associated with COVID, and now they're trying to manage things in the, right? We start to think about the impact of trauma on everybody who's involved in the care for the client that we're providing direct services to. So when we are talking with families about how to start to look at safe environments at home, I encourage you to start that conversation with assessing for any traumatic events that are occurring in the home. Sometimes, and this might not be okay, so check with your supervisor or agency, I might assess for a parent if they have any trauma history that's associated with like abuse or neglect. Because if they do, and they have a child with very challenging or aggressive behaviors at home or self-injurious behavior, sometimes we start to see some of those reinforcement systems occur in the parent. And so part of it is teaching the parents skills to manage their own responses to then be in a better space to integrate the interventions we're talking about. So safe space at home. Sometimes I will have parents kind of walk me through what their house looks like. So that could be in person. I've had families meet with me on telehealth, and they'll kind of camera their self around their home if they feel comfortable. And if not, then we just kind of talk about what their environment looks like at home. And then we start to problem solve what their resources are. So for example, I'll often start with, let's remove medications, sharps, things that can be used as weapons. That's my first place always, because those tend to be the highest harm. And I will problem solve, like, where could you put them? What are your resources to gather a lockbox or put them up high or get child locks, right? So we're really problem solving the ability to access those resources. And then we'll look at how we maybe restructure some of the environmental things that are at home. But those conversations don't go anywhere if there's trauma events happening at home and I'm not assessing for it. So I do encourage you to talk with your supervisors or, do some research on how we start to integrate trauma-informed care from a whole, like, kind of family or community perspective. And I have found myself in many situations not assessing for trauma. I've learned and gotten better over the years, but in my early years, not assessing for trauma that's happening at home, assuming a parent is not engaged with services, and then responding to a family who's not engaged as it being a non-engagement issue versus looking at what other factors could be contributing to that. And could those factors be due not only to things like transportation or access to resources, but also due to possible trauma happening in the home. I would also kind of point out that people who meet criteria for post-traumatic stress disorder overall report greater difficulty disclosing their traumatic event than people who don't meet criteria. So I just point this out because we are working with parents who have their own mental health challenges, physical health challenges, may have a post-traumatic stress disorder diagnosis, and I may assess for trauma and they may not tell me. And I would encourage you again that this is a situation to just assume trauma and readjust how we're providing interventions based off the fact that, especially if I know that the client I'm working with has like behaviors for property destruction, significant challenging behaviors, aggression, self-injurious behavior, those would be really good indicators to me that traumatic events are occurring at home as well. The next piece to look at is how we're providing choice. And honestly, choice and preferences is both a core competence in trauma-informed care to reduce the risk of re-traumatization, but it is the subject in which there is a lot of research in behavior analytics that support choice making, both as a dependent and independent variable. So there's a lot of information in behavior analytic literature that talks about the importance and emphasizes integrating procedures and practices that support client control, choice, autonomy, building independence. And really, for trauma-informed care, this intervention really decreases the likelihood of re-traumatization. So we're looking at providing opportunity within the context of intervention where we are constantly assessing for preferences. Sometimes I've worked with staff who are, engaging in whatever reinforcement system we have set up, and they're like, oh, they're not responding to the reinforcement system. And I'll say, when was the last time that you conducted a preference assessment? And oftentimes I get the answer, I don't know, it's been a while, right? So really thinking about how we're integrating preference assessments into sessions more regularly, making sure that we are communicating the options for choice and decision-making because we're really looking at helping people regain control in parts of their daily life, which can be really important. When we translate the trauma-informed commitment of choice into behavior analytic language, there's not a huge stretch, because again, it's a really highly researched, dependent and independent variable. Even beyond this, choice is a really important and integral factor in our ethical practice, and we'll talk about some of the ethics in just a little bit. So the operational definition that I have always appreciated for this is defining choice as the emission of one among two or more alternative and usually incompatible responses, and preference is identified as the selection of one alternative more frequently than another when there's like successive choices. So we're really looking at arranging opportunities for clients to make choices and express their preferences, so they are different. So thinking about things like starting sessions, and if the client's able to, like, let them determine the order maybe of activities that are engaged in, assessing for preferences ongoing. Sometimes when I've taken, clients into the community and I know that there are multiple places we're working on skills, I can let a client choose which community event we're going to or community location we're going to. I have families who prefer to meet in person, and I have families who really prefer telehealth, and I'm able to bill for telehealth. So I give them a choice. In the next 3 weeks, I'd like to see you in person at least once. Which week would you like that to be, right? Or would you like to meet with me in person or on telehealth, right? So even when we start to integrate small choices like that into our sessions, we really can see an impact on client outcomes and engagement. And finally, looking at skill building, again, trauma-informed care literature identifies that what they call recovery from trauma really occurs in relationships that support skill development. For our purposes, we're really looking at learning functionally appropriate replacement behavior. So that's the recovery from trauma, and how we start to build skills into our sessions to facilitate that. We really look at the importance of acquiring adaptive behavior, really helping in the building of independence and autonomy. And ABA, again, is really well positioned to probably provide information to other disciplines about skill building. So choice and skill building are two areas that applied behavior analytics already supports in the literature and interventions that we're doing already. And so if we consider this as part of trauma-informed care, I would encourage you all to see that you're already practicing some of this in your kind of regular provision of services. So we are really looking at, skill building as a cornerstone of ABA. It goes all the way back to the Bear, Wolf, and Risley article in 1968. This is something that ABA has really been built on and is a very integral part of how we deliver services. So really thinking about how are we assessing where our client's skill level is at? How are we identifying the functions of behavior in the context possibly of trauma events? And then how are we teaching skills that both provide option for functionally appropriate replacement behaviors, but also teach our clients to respond differently to trauma triggers if they're present in the environment? I do want to talk just a minute about seclusion and restraint. And I will give my little disclaimer here that I have a lot of very mixed feelings about the use of these two things. So you're coming from my lens of that. I do encourage you to start to think about these procedures and how they are the most restrictive procedures that we can engage in when providing services to our clients. From a trauma-informed care perspective, seclusion and restraint are not trauma-informed at all. Actually, a lot of the literature in many disciplines really encourages the avoidance of these two procedures due to the likelihood that re-traumatization can occur when they're used. However, I also recognize that when we are supporting individuals who have severe, imminent, unsafe behaviors, sometimes our response has to meet that level to keep everybody safe. So I'm not sitting here and saying, never use them ever. I used to be a trainer for, a physical restraint protocol. I don't work anywhere that I have to do that anymore. So yay. I think the likelihood that these two procedures can be used inappropriately are very high. And so if you are in a place where seclusion and restraint is used, I encourage you to be very aware of the legal expectations, if they exist, what your agency rules are around it. So for example, again, I mentioned I live in New Hampshire. New Hampshire has a 30-minute max hold, and then you have to release no matter what. But some states don't have any laws around restraint or seclusion. The kind of purpose of talking about this is to really consider the use of less restrictive measures that are proactive procedures that decrease the likelihood that you'll have to engage in these reactive procedures. So seclusion is defined as the involuntary solitary confinement of an individual, and restraint is referring to any method, so physical or mechanical or material, or the use of equipment that immobilizes or reduces an individual's ability to freely move his or her arms, legs, bodies, or head. Restraint in many places can include the use of medicine intervention to restrict movement as well. So there are many studies that show the use of seclusion and restraint can result in psychological harm, physical injuries, and death to both of the people who are subjected to and the staff that are applying these techniques. Injury rates to staff in mental health settings specifically that use seclusion and restraint have been found to be higher than injuries sustained by workers in even high-risk industries where, accidents are prevalent. Restraints can be harmful and often re-traumatizing for people, especially for those who have a trauma history. And beyond the physical risks of injury and possible death, it's been found that people who experience seclusion and restraint remain in care longer and are more likely to be readmitted for care. So when we're using these reactive procedures, people are more likely to stay in, especially like residential or like hospitalization longer than those who don't experience seclusion or restraint, and they're more likely to kind of readmit into those services. So really thinking about that from research is important. As I mentioned, behavior analysts, RBTs, we work with the toughest behavior problems, especially within some of the populations that we are supporting. And use of restraint and seclusion is a default response to crisis when other interventions have not yet kind of been effective, or the behavioral escalation presents the threat of imminent harm to the client or other people. So this is just a food for thought slide, kind of. If we are committed to integrating trauma-informed care, and we know that seclusion and restraint are not trauma-informed care practice, but a lot of places need to use them because of the challenging behaviors that we're seeing, how do we start to look at using all of the things that we've talked about, talking about trauma, assessing for trauma, creating a safe environment, really focusing on building rapport in the relationship, providing as much choice and preference as we can, and really working on skills antecedent interventions to decrease the likelihood that we will have to use seclusion and restraint. I will encourage you to think about most individuals have a strong private event reaction when they are experiencing seclusion or restraint. And it is the situation in which all choice and control are taken away. And when we are looking at providing opportunity for choice and control, this is kind of the complete other end of that spectrum. And sometimes the procedures that we use to keep our clients safe and are necessary can cause the environment for that client to feel unsafe. And so that's where it kind of comes into conflict with trauma-informed care practices. Some ethical considerations, kind of looking at how trauma-informed care really is already in our ethics code, even if it's not labeled trauma-informed care. And I won't read through all of the codes, but I do encourage you to be familiar with them. But some that really do highlight the things that we've talked about today is thinking about the core principle of treating others with compassion, dignity, and respect. Looking at codes 107, so cultural responsiveness, that was a hard word, and diversity. How are we aware of our own biases and our own personal responses in treatment? Are we involving clients and stakeholders in the development of goals, really looking at strengths-based approach? Are we being evidence-based and proactive in our designing and implementing of assessments and behavior change interventions? Are we assessing about minimizing the risk of those interventions? And when we talk about like educating around trauma and describing what we're doing, it does fall under describing behavior change interventions before implementation. And then what is our overall kind of requirement or responsibility to our clients in providing really effective care? Again, some of this came from the article I talked about before, the Ramajaran article. Again, it's a really great article. There are, in my research for this training, there are many articles that are in review that will probably be published sometime this year that start to look at trauma-informed care. Some of them look really good in regards to our ethics around trauma-informed care and how we start to integrate this into our work as behavior analysts. So you've heard me say assume trauma probably a bunch of times through this training. And now in hindsight, I'm like, should I put this slide way at the beginning? But we might not always know if somebody has experienced a traumatic event in their life for many reasons. I might not have access to the people who had the information from an early developmental perspective. The client themselves may be old enough, but not know their history fully. Somebody may not feel comfortable disclosing a trauma history to me. And so even if I ask sometimes, I still may not get information that indicates that somebody experienced a traumatic event. However, if we assume trauma, then the interventions that we put in place are more likely to be trauma-informed and are more likely to have positive and successful outcomes for everybody who's involved in care. It creates opportunity for us to look at our environmental management. What kind of antecedent interventions are we providing? We would take a reinforcement approach first instead of jumping to more restrictive or punishment procedures. It helps us be aware of how we start to interact with other people in the context of service. And oftentimes I live in a place of don't assume, right? So I don't want you to assume why a parent isn't engaging. This is one situation where I'm going to give you a pass to think about assuming trauma. Because if I assume trauma and I then function from a trauma-informed care perspective, there is nothing that I'm going to put in place in the context of services that could be significantly harmful to the people that I'm providing support to and intervention to. The most that it does is it makes me aware of my own behavior. It helps me work to establish rapport, teach skills, manage the environment, and provide choice. And so it's best if we can have information about traumatic events because it informs the reinforcement structures that are in place, stimuli in the environment that may act as triggers specific to that individual. But if I assume trauma without information, specific information, I'm still going to engage in really positive and effective care. So I just wanted to touch base briefly on compassion fatigue. I am not going to go too far into it in this training. There is a compassion fatigue burnout training in the store, I think, that you can purchase, which will go more into ways to manage this. But I think we can't talk about trauma and trauma-informed care without mentioning compassion fatigue. So experienced behavior analysts often live with past clients and client experiences kind of bouncing around in our memory and in our head. Sometimes our clients that we support now can be really challenging, and we have behavioral and emotional impact from that. And when we start to think about, why are these clients still kind of in my head? Why am I thinking about these clients? Why did these clients feel really challenging to work with? Or why did I feel, maybe I wasn't as successful as I could have been, right? There's so many questions that come along with it. When we start to talk about trauma and trauma-informed care and trauma events occurring in people's history, it's likely that some of those past cases that we've worked with include clients with past trauma experiences that maybe weren't identified or addressed. And, we're really looking at how that might start to impact us on a long-term effect from working with really high needs or challenging clients. So compassion fatigue is when a clinician begins to feel the effects of trauma from a single event or ongoing exposure to really challenging behaviors of a client. The definition specific for compassion fatigue is the emotional, mental, and physical exhaustion that comes from caring for traumatized individuals or individuals who have high emotional needs. If you are experiencing compassion fatigue, you can experience the distress even after interacting with one child who has a trauma history or meets criteria for post-traumatic stress disorder. There are two components to compassion fatigue. So the first is the feeling of caring for somebody who's suffering. And usually our clients are not coming into services because they aren't experiencing distress in some way in their life. And the second part is the motivation that we have to relieve that suffering or to help them learn the skills so that they're not experiencing that distress. When we begin to feel compassion fatigue, the symptoms can feel similar to traumatic exposure or post-traumatic stress disorder, even though I'm not saying that as a diagnosis. So we might avoid stressful situations, see impact in our own behavior, mood changes, relationship impacts, and things like that. Some ways to think about managing compassion fatigue is making sure that you are getting good supervision and support, looking at your access to resources, working in supervision and kind of on your own on how we build self-compassion and self-efficacy, engaging in self-care, and building work-life flow. So as I mentioned before, there is a compassion fatigue training. It's called the Empowered BCBA, Strategies for Prevention and Managing Burnout and Compassion Fatigue. And you can find that in the store at Master ABA. All right, so we're coming to the end of lesson 3. And I always like to give people their next steps, which I did mention earlier. So in the resource section, there are some resources for you to use that come with this training. There is a self-assessment and a workbook that I encourage you to take a look at and fill out. And the self-assessment will help identify areas of areas that you'd like to improve in or learn about trauma-informed care and set some small goals for yourself to increase your knowledge. I encourage you to think about one thing that you can do today, or if it's a weekend or a nighttime tomorrow with your clients, to start to assess and create a safe environment for the people that you're providing services to and for yourself. And, think about what is one actionable step beyond that you can take to expand your knowledge about trauma-informed care. So those are a lot of next steps. You can challenge accepted and do all of them, or just pick one. But I really do encourage for everyone who's attending this to think about how we can start to assess for trauma and integrate some of the trauma-informed care practices we talked about today. So lesson 3, we went over some things to integrate into practice, some language that you can use to assess for trauma. We talked a little bit about compassion fatigue, and I hopefully will have people accept the challenge to start to integrate trauma-informed care into their practice. This is the end of our training. Our next steps are to take the quiz that applies to this lesson. There is an evaluation form that you don't have to fill out, but we do ask if you have the time to fill it out. We read every single one, and I adjusted some things for this training based off responses and feedback that I got from my last training. Finally, if you have any questions, feel free to email Master ABA, but also use the forum. I think it's a really good opportunity to ask questions and have some dialogue. Once you complete the quiz, you'll have access to download your CEU certificate. I want to say thank you to everybody who has attended this training. I know it's a lot of information, but if you can't tell, I think it's very important. So hopefully there's something applicable to your current job environment. Please feel free to check out all the other really awesome trainings that are on Master ABA. There's a ton of skill and collaboration and parent training and really cool trainings and information on the website. Thank you so much.
Thank you, Nikki. That was fabulous.